Yeah, Pratik, should we start? Hello, good evening, everyone. I'm Dr. Amit Gupta on behalf of MedTalk. Welcomes you all for our topic of discussion on very common condition known as PCOS. As we know, PCOS is one of the most common endocrinopathies among the women of reproductive age group, and global prevalence is over 116 million. Even in India, prevalence of PCOS is increasing. So, to share expert advice on PCOS, we have with us one of the renowned endocrinologists across country and very common and known face on digital platforms. So, please welcome none other than Dr. Sanjay Kalra, sir.
Good evening, everyone.
Yeah. Good evening, sir. Sir, today's topic is on management of PCOS and expect the best outcome. So, before starting the session, so I would just like to know from you, how do you define PCOS? Like, what is the basic criteria for definition of PCOS, sir?
That's an important question because this is a term that has been used, misused, abused so many times, not only in the medical field but also in lay language. So, first of all, to set things straight, PCOD, polycystic ovarian disease, is a misnomer. It is an old term. It is not used anymore. The correct uh, the correct abbreviation is PCOS, and the full form is polycystic ovary syndrome. Many of us use ovarian syndrome, but actually it is an ovary syndrome. There is a difference. If the primary pathology had been ovarian, then perhaps an ovarian syndrome terminology might have been correct. But here, what we are saying is that it is a syndrome. A syndrome is a constellation of a group of symptoms, signs, and laboratory abnormalities or imaging abnormalities. So, symptoms, signs, and lab abnormalities put together, that's the syndrome. And this syndrome is characterized by polycystic ovary. So that means the image of the ovary is polycystic. So PCOS is the right term. It's a syndrome, and it's defined as a syndrome where there is polycystic appearing ovary along with anovulation and or hyperandrogenism. So again, there are different diagnostic criteria. Perhaps we can come to them later. But these are the three things that contribute to a diagnosis of PCOS: anovulation, polycystic appearing ovaries, and hyperandrogenism.
Yeah, thank you very much, Dr. Sanjay sir. Sir, a very important pointer we are coming now. Uh, how do the patient can understand that they are suffering from polycystic ovarian syndrome, and what are the diagnostic criteria for PCOS? So, can you just put in some highlight over this diagnostic criteria of PCOS, sir?
So, whenever we diagnose a disease, whenever we label someone as having PCOS or any other disease for that matter, that is a matter of great responsibility. And we should do it in a rational manner, in a pragmatic manner. Many times we get ladies, women, girls coming to us who are obese, and an immediate label on them is, I have PCOS. That is not correct. Every obese lady does not have PCOS. There will be others who will come with hirsutism, with hair growth, and then they will say, "I have PCOS." So that may be true. Hirsutism is a is a sign of hyperandrogenism, but it is not necessary that every hirsute lady will have PCOS. And third, people will come with infertility, and then they will blame PCOS. So that may or may not be true. So we should be aware. So first of all, we should be aware that everyone with the symptoms and signs that we are going to speak of will not have PCOS. PCOS is a diagnosis of exclusion. Before you diagnose an ovarian pathology, remember to rule out a pituitary, thyroid, and adrenal pathology. We'll repeat this later on in today's talk. Remember to rule out pituitary, thyroid, and adrenal pathology before you label PCOS. And even when you're labeling PCOS, you've asked of the diagnostic criteria, we'll come to them. Remember that PCOS is part and part of a constellation, a larger constellation known as metabolic syndrome. So there may be other aspects of metabolic syndrome in a lady, maybe exogenous obesity, right? Maybe diabetes mellitus, And a polycystic appearing ovary just happens to be part of that constellation. So that doesn't mean that we have to label every metabolic syndrome lady as having PCOS. So how do we actually diagnose PCOS? We have to have at least two out of three criteria. So once we know these, then we are on firm ground. We know whom to label, whom not to label. The first criterion is hyperandrogenism. How will you diagnose hyperandrogenism? Either you do a serum androgen, that is serum testosterone, and you find that it is higher than normal, or you look at it clinically. Clinically, you may find a lady with male pattern baldness, that is androgenic alopecia, with acne, or with hirsutism. Now, once again, every lady with acne or hirsutism will not be polycystic ovary. But so far we have got one diagnostic criterion, that is hyperandrogenism, which can be clinical or it can be biochemical. The second diagnostic criteria is anovulation. So how will we diagnose anovulation? Again, you can diagnose it clinically. Maybe there is menstrual irregularity, oligomenorrhea, or no periods at all, secondary amenorrhea for 3 6 months. You've ruled out pregnancy. There's no other cause. Or you might want to do it through imaging. Follicular study is being done regularly, and you see in that particular lady, in that particular cycle, there's no follicle, no ovulation. Or you might wish to use hormonal assays. You can do urine testing, you can do blood testing, and you see that there is no LH surge, there's no ovulation. So this is the second diagnostic criterion, anovulation. So first was hyperandrogenism, either clinical or biochemical. The second is anovulation, either clinical, biochemical, or based upon imaging. And the third is imaging, that is ultrasound, polycystic appearance of ovaries on a transvaginal ultrasound. Why do we highlight that? Because the diagnostic criteria use TVS. In India, mostly we use TAS, transabdominal ultrasound, in unmarried ladies. There are multiple factors which contribute to that. But do remember that a TAS may not give you the right visualization, and it is certainly not going to give you the right visualization in an obese lady. So still, all these three criteria are there, and current guidelines say that out of these three, if any two are present, you can label the lady as having polycystic ovary syndrome. But at least two out of these three have to be present.
Yeah, thank you, sir. You have rightly explained the diagnostic criteria for the PCOS. So again, sir, coming to a very important pointers, like your diagnosis also, you have mentioned that ovulation, anovulation, or maybe hirsutism, or maybe infertility. So we come to a management part. So what are the goals for the management of PCOS, sir?
This is important, and to understand our goals of management, we should understand the pathophysiology. What is it that brings hirsutism and or hyperandrogenism and anovulation and this polycystic appearing ovary and also metabolic syndrome, all these other aspects of PCOS that we see? What is it that brings them together? The answer is insulin resistance. Now, some of us may get confused, but actually we should not. When we study endocrinology, we tend to study it in a Newtonian fashion. What does Newtonian endocrinology mean to me? It means it follows Newton's laws. Every action will have an equal and opposite reaction. This is how physics was studied long ago. Still, it is studied like that. And when Newton's laws were created, there were so many physicists in the world who said that now there is no need to do a PhD, there's no need to do research in physics because all the secrets of the universe have been explained. Then quantum physics came in. Now, what does quantum physics say? Quantum physics says that each and every particle or each and every mass does have waves or energy. And these waves and masses, these waves and particles, they intersect with each other, the energy and the masses. So sometimes you see the quantum, sometimes you feel the quantum. Now, this polycystic ovary syndrome is quite a slippery eel to catch. Let me put it mildly. In Hindi, एक बहुत फिसलाऊ बाम मछली है ये. But once we understand that we should not view this from a Newtonian perspective, we should view it from a quantum endocrinology perspective. Now then things settle in place. Quantum physics, quantum mechanics. go on to quantum endocrinology, and now let's look at the ovary as a quantum. So, multiple interrelationships all intersecting with each other. It is difficult to find out which relationship came first, which came later. Like so in Newton's law, action has a reaction. But here you're not even able to figure out which action is coming first. But still, to understand, the basis would be insulin resistance. So, what are the aims of treatment? Let us just classify them as three to understand. So, this rubric which helps me understand. First aim is I should tackle insulin resistance. I should be able to sensitize the receptors to insulin. But before that, there are predisposing factors, causative factors that have led to insulin resistance. I should handle those. And after that, there are downstream effects of insulin resistance. So I must handle those as well. So these are the three effects. Sorry, I apologize for that. So these are the three effects that we have. And once we are able to bring this in our place, now suddenly the management of PCOS will become so simple, so easy, there will be no issue at all. Let's do these one by one, Dr. Amit, if you allow. So
Yes, sir. Yes.
yeah, let's focus on insulin resistance. Now, insulin is a hormone. It comes from the beta cell. But that's the beauty of endocrinology, that the tiny glands that we have you ever realized that the beta cell weighs only 0.8 gram? It doesn't even weigh 1 gram. The beta cell weighs 0. All the beta cells put together, they weigh 0.8 gram in an adult human being, and maybe 1.2 gram in an obese adult. So average, let's take as 1 gram. This 1 gram produces insulin. Insulin is a hormone. It works like a key which opens various receptors. So we are all aware of, now we are on Newtonian ground in endocrinology. But these receptors are found all over the body. Uh, in diabetes, we speak of the skeletal muscle, the adipose tissue, and the liver. But that doesn't mean there are no insulin receptors in the brain or in the heart or in the ovary. They are there everywhere from top to bottom. Now, insulin acts like a key to open various receptors, but all these receptors have different sensitivity. There is differential sensitivity. So, in one individual, it is possible that there may be very good sensitivity at the level of the skeletal muscle and adipose tissue, but poor sensitivity at the level of the liver. In others, there may be insulin resistance at the level of the ovary. So, how do we correct all this insulin resistance? The simple answer is insulin sensitizers. So the classic drug that we have, it is known as a contemporary classic. We also use the term midlife maturity and maiden charm. The reason is because it's more than 60 years old now. So that is midlife maturity for metformin. And maiden charm because we still keep on learning new and new aspects about its mechanism of action. So metformin will help us in improving insulin sensitivity. But it's not just drugs that we have to use. Like I said, what are the causative factors which are contributing to insulin sensitivity? So if we can focus on those, if we can optimize lifestyle, reduce body weight, increase exercise, all these things in themselves will also improve insulin sensitivity. When you exercise, the insulin sensitivity in the skeletal muscles goes up. It improves. The insulin sensitivity improves. So resistance comes down. And that will have a domino effect or maybe a collateral effect, a parallel effect upon the insulin sensitivity of the ovaries as well. In OPD, sometimes I find it difficult to explain. So then I do tell my patients, I tell them about the weight of the beta cell, I tell them about the weight of the ovary, and I say that you must try to lose weight. The girl answers back saying, I've tried everything in the world and I'm not able to lose weight. I say, it's just about maybe half a kg, 1 kg, lower abdominal weight. Why don't you try to lose it? All we need is half a kg. Why don't you begin skipping? And if you're able to lose all that fat around the ovaries will become more sensitive to insulin. So this is a way of visualizing, a way of explaining to the patient and also to ourselves that it is important to address insulin resistance and also the factors that contribute to it. So this would become two aspects of management. Now, the third aspect is the downstream effects of polycystic ovary syndrome or insulin resistance. How do we classify the downstream effects? So this is what I do in my practice. M for metabolic, Dr. Amit. Metabolic
Yes.
would be dysglycemia, diabetes, hypertension, obesity, heart disease, dyslipidemia. So M is for metabolic. M is also for menstrual. So menstrual irregularity, oligomenorrhea, sometimes amenorrhea, usually disturbed periods. So no set pattern. M is also for maternity. The chief complaint is not menstrual regularity. The chief complaint is subfertility. So the lady doesn't come with anovulation as a presenting symptom. The presenting symptom is inability to have a baby even 1 year after marriage, after trying. So M for metabolic, M for menstrual and maternity. M is also for makeup. Just a way for me to remember. Makeup would mean hair loss, hair fall, acne, darkening of skin, acanthosis nigricans, hirsutism. A big issue for many girls and ladies. And then another M, which is ignored sometimes, is M for malignancy, because the risk of malignancy also increases in PCOS. That's because endometrial hyperplasia is there. And one last M would be mood. Because of polycystic ovary syndrome and because of the phenotype that is associated with it, maybe obesity, maybe hirsutism, there's a reduction in self image, self esteem, and that can lead to mood disorders. So, these are some issues that we face based on what M the patient has come with: maternity, menstrual, metabolic, makeup, mood, or malignancy. Whatever her concern is, we treat that. So this is in a nutshell how we manage PCOS, and so far we have created for ourselves three verticals. But perhaps as we go on in today's discussion, we still have 10 minutes left. Let's speak more and
Yes.
more in more detail about this.
Yes. Thank you very much, sir. You have rightly explained by 1M that what are the challenges and what are the goals for the management of PCOS. Sir, again, one of the interesting challenges for the PCOS women face due to infertility. So, what is your opinion on the challenges of PCOS women due to infertility?
This is perhaps the main cause with which the main complaint with which ladies will present, both in the obstetric and gynae OPD as well as in the endocrinology OPD. So, subfertility is becoming more and more common, and ovarian pathology, especially polycystic ovary syndrome, is one of the most common drivers. I would say the most common cause of infertility, subfertility due to female causes. So, this is a challenge. And the challenge is, as an obstetrician, as a gynecologist, I'm assessing all the various factors. How do I do it as a gynecologist? I do male factor, female factor, and then whether they are able to meet each other. In female factor, I look at the ovaries, the fallopian tubes, the uterus, and the cervix, and also, of course, the lower part, because there I want to see whether consummation of marriage has occurred or not. But it's relatively easy for me to assess the anatomy, to assess the structure of the lower reproductive tract, and even the uterus. But when it comes to the ovary, I can do an ultrasound. For function, I have to rely on many other surrogate markers, maybe on LH, maybe on serum testosterone. And even when I do that, I'm not very sure of whether I've got a hang of the milieu of the ovary. What is the quality of the ovary? What is the quality of the oocytes? What is the state of insulin sensitivity within the ovary? These are things which are difficult for me to assess. So these are some challenges that we face.
Okay, thank you very much, sir. You have rightly explained about the challenges of PCOS women due to infertility. So now we come to a very interesting topic of PCOS discussion is treatment options for the infertility women with PCOS. And again, what is the potential benefit of metformin in the management of PCOS?
So, when a lady comes to us with PCOS and a chief complaint of subfertility, most of the third line drugs, if you remember, we had drawn three verticals. So,
Yes.
most of the treatments that are used for management of hirsutism, mood disorders, malignancy, menstrual regularity, all these cannot be used. I would like to use a menstrual regulator, but with that, I cannot plan pregnancy. I would like to use various drugs, anti-androgens, but with that, again, I cannot plan pregnancy. So my choice is limited. So now I have only two verticals to work upon. First is lifestyle modification. So we'll do that. Second is insulin sensitization. We can do that with metformin, and we can do that with another group of drugs known as inositols. And this is a very beautiful field of pharmacology. We'd like to speak about that in more detail. Third is when you are planning ovulation induction, then drugs like clomiphene and letrozole can be used. They should be used under the supervision of a gynecologist. And these are the three drugs that we can use. In general, if you want best results, all three should go concurrently. Lifestyle modification and weight loss, that's one. Second is metformin and the inositols. And the third is clomiphene or letrozole, not both of them together. And do remember when your patient buys clomiphene, especially, make sure to see what strip she has got, because so many times, once recently we had a doctor who ended up buying clonazepam instead of clomiphene. And similarly, when you are using metformin or when you are using inositol, like Myquiro, make sure that the patient has bought what you are saying, because you might have written a sustained release preparation. Patient goes and buys an immediate release one, and that causes hypoglycemia. You might have written an inositol with 4 is to 1 ratio of MI to DCI, but patient goes and buys 40 to 1 ratio, and then the purpose is not going to be served. So be aware of the need for medication counseling, and also ensuring that the patient has taken the right medication.
Yeah, thank you very much, sir. You have rightly explained all the three important aspect of management protocol of PCOS, like lifestyle modification, metformin, and inositol, as well as clomiphene citrate and letrozole. So now we have one more question on a very interesting aspect, like as you have discussed about the inositol. So inositol is a nutraceutical. So, do you believe that does inositol supplementation improve the PCOS associated complications as well as reproductive aspects, sir?
Oh yes, I believe that, and I believe that very strongly, very strongly. Initially, Dr. Amit, we had spoken about physics, so we spoke about Newtonian endocrinology and quantum endocrinology. Let's speak about chemistry now. Now, this simple element, carbon can come to you as a diamond, it can come as graphite, but it can also come as coal, isn't it? So, are all three
Yes.
all the same? Yes, they are all carbon, but are they different? Of course, they are different. You try giving a ring of coal to your loved one instead of a ring of diamond, and then you will realize the difference. So, so that is the difference in chemistry. A similar thing happens with sugar. Now, we use the word sugar colloquially. Again, we use it and we misuse it. Sugar is not one entity. There are so many types of sugars. You can have sucrose, fructose, galactose, mannose, and you can also have inositols. All of them are sugars. They have the same chemical formula, but they have totally different uh, mechanisms of action and totally different functions, physiological functions in the body. Even in the inositols, we have different types of inositols. There are many, but the two important ones are MI, that is myoinositol, and DCI, D-chiroinositol. Now, these uh, these sugars or these chemicals, they work as second messengers, and they are insulin sensitizers. So, what is a second messenger? Let's put it simply. Suppose I am traveling from maybe from one end of Mumbai to the other end, and I see that there's a traffic jam. So I might want to change my route. I'll take a detour, go through some side lanes, and then finally I will reach my destination in time. That side lane that you're using is a second messenger. Similarly, that is what happens in the body. When you look at the entire physiology, you will find that insulin does not have any support in the body. There are so many counter regulatory hormones which produce hyperglycemia: growth hormone, adrenaline, noradrenaline, glucagon, cortisol, such a long list of counter regulatory hormones. But no one to support insulin. The best you have is IGF-1, insulin like growth factor 1, but that does not work in glucose homeostasis. How is it that the body could have done such a thing in evolution? Just 1 gram of beta cell and no one else to support. Now, the thing is, the body is wise. The one who created evolution is wise. And what they did, they created second messengers for us. So, to support insulin, we have the inositols. And what the inositols do is, through these pathways, through these, again in Hindi, through the gullies and the kuchas and the tiny lanes, narrow lanes of body physiology, they help us achieve insulin sensitivity. So, how do they help? They help in improving insulin sensitivity, and because of that, they help in improving all the downstream effects. So, for especially for fertility related issues, they are really effective.
Yeah, thank you very much, sir. You have rightly explained about the inositols. Now, one last question from my side, sir. I would just like to understand that in your previous question, you have discussed about 40 is to 1 ratio and 4 is to 1 ratio. And what is your opinion about MIDCI 4 is to 1 ratio compared to 40 is to 1 ratio? And then you can conclude the session by giving a take home message for our audience.
There has been a lot of discussion on this, and let me explain why this discussion has taken place. So then we understand, we are clear. Now, we want to achieve a physiological ratio of MI to DCI. If we can achieve a physiological ratio with a pharmaceutical preparation, we will achieve physiological results. And the physiological result that we are aiming for in this particular situation is ovulation, fertility. If you look at the urinary ratio of MI to DCI in normal controls, you will find that it is about 3 is to 1. But when you look at relatives of people with type 2 diabetes, then the ratio goes up. So more of MI, more of myoinositol. And when you look at people with type 1 or type 2 diabetes, then the ratio goes up to 20 is to 1 or so. So now it depends upon what population you are studying. If you are studying a diseased population, that is type 2 diabetes, you will find a high ratio of MI to DCI. But if you're studying healthy controls, then you will find a low ratio. So that is why if we want our patient to achieve good health, then we would be serving her interest in best if we used a 4 is to 1 ratio of MI to DCI. And the standard preparation is 550 milligrams of MI and 150 milligram of DCI. That is the standard preparation per capsule. And you might want to use 2 or 4 capsules per day. That is up to it depends upon the patient's weight and also clinical situation. If we end up using a high ratio, we are actually worsening the pathology. We are worsening the pre existing pathology of the patient.
Okay. Thank you very much, sir, for your insight. And what is your final take-home message about the management of PCOS and expect the best outcome? And then we can conclude the event, sir.
So, PCOS is a very wide, a very heterogeneous spectrum. Sometimes we find it difficult to understand. But if we understand the basics of physics and chemistry and biology, then it becomes very easy to conceptualize and very even easier to manage. So, lifestyle modification, focusing on insulin sensitivity, and using whatever drugs are required to handle whatever chief complaints the patient has come with. That is the way we should work. Do not overdiagnose the syndrome, but also do not neglect it. And if you're focusing on maternity, on fertility, Then we need to focus mostly on lifestyle modification, weight optimization, and insulin sensitization. Do not uh, feel that just because metformin and inositols are freely available in the country, do not feel that they have no value. They are actually very strong, very potent molecules which will help your patient achieve what she wants, which is pregnancy. And the same way that you know how to differentiate between diamond and coal, or maybe you know how to differentiate between fruit and honey and table sugar. In a similar way, there are differences between the different inositol preparations. So when you're using metformin, especially in non-diabetic women, prefer a sustained release one at night that will not cause hypoglycemia. It will not cause GI disturbance. And whenever you're using an inositol combination, use a 4 is to 1 preparation of MI to DCI. And this will give us the right results, the desired results.
Yeah. Thank you very much, sir. It was indeed a wonderful session, and we appreciate all your valuable insight and your time for our audience. So, thank you very much, sir.
Thank you. And I wish you all the best in your career. Wish all the best for our patients as well. Jai Hind.
Jai Hind, Jai Hind. Thank you, sir.